Hi, my name is Nancy and I have a case study presentation for JR who came for a follow-up visit with chief complaint. I am doing well. He is a 70-year-old Hispanic male who joined U.S. Army at the age of 18 years old. He completed high school diploma, retired logistics specialist for the Army. He speaks English. He is his own source of information. He reports being divorced ×2 and he is Baptist by religion. He was born in Mexico, moved with his mother to United States when he was 10 years old. Reports that his father was physically abusive to his mother and him as well. His father was alcoholic. His mother died of COVID-19 at 95 years old, about a year ago. He lives alone. He has a son and 2 grandsons who live in California and a brother who lives in California as well. He was drafted to Army during the Vietnam War. He witnessed a lot of discrimination and maltreatment in the Army. Working diagnosis and symptoms. He witnessed rape in boot camp at the age of 18. Report many traumatic events in the past, including the death of his father when he was 8 years old. He didn't disclose what caused the death of his dad. He lost his daughter at 17 years due to blood clot in her lungs. He also reported abusive wife who showed physical and emotional violence. Reports that the second wife was the one who was violent. Frustrated that his family lives in California and he's here by himself. Report hearing voices. Mostly the voices are self-critical and not commanding. Not sure if the voices are genuine auditory hallucination. He indicated he moved to Colorado because he met his wife over the internet and he ended up divorcing the wife due to physical and emotional abuse. He reports not having a lot of friends. He has decreased appetite. He drinks beer once a week, about 8 to 10 cans. Over the weekend, he reports some anxiety due to pandemics and politics. He denies substance abuse, self-injury, suicidal intent, attempt, and ideation, as well as homicidal ideation, and denies destructive or violent behavior. He was diagnosed with PTSD and MDD. Some of the differential diagnoses to consider include generalized anxiety disorder, PTSD, MDD, personality disorder, alcohol use disorder, and psychosis. Medical history include diabetes, gout, meningitis, hearing loss, and stroke. He denies asthma, chronic pain, birth defect, and impaired mobility. He wears prescription glasses. He wears hearing aid. He reports that he lost his hearing from meningitis. He also reports neuropathic pain related to his diabetes. His vital signs are stable. He has a BMI of 21.9. He is not sexually active. He indicated that COVID-19 prohibited his family from getting him back to California. Some of the coping mechanisms, healthy ones: he reads newspaper and takes a walk. He likes cooking and listening to music. He also have a dog, so he gets dog therapy. He drinks beer. Some of the ego and defense mechanism is isolation, that he lives by himself, suppression. He didn't want to talk about. He didn't want to go into details on his abuse, his physical abuse and maltreatment. Introjection: when his dad died, he kind of took like father figure. He was the voice of his mother. He also exhibits dissociation. Denies any inpatient hospitalization. He tried Zoloft, Prozac, temazepam, Neurontin, and Wellbutrin in the past for depression. He's allergic to Zoloft because it kept him awake. Temazepam made him dizzy. Stopped therapy 2 months ago due to lack of motivation. He endorses individual therapy that it helped him with depressive symptoms, and he responded well to Wellbutrin and Neurontin. Current medication is on Wellbutrin XL 150 milligrams daily for depression, Neurontin 400 at bedtime, Prazosin 2 milligrams at bedtime, family support, spiritual support, and CBT. Assessment. He exhibits nightmares. He reports sleep disturbance. He is irritable. He has decreased appetite. He reports having recurrent dreams about his father's maltreatment and abuse. He doesn't remember the specific details about the dream. He avoids going to Fort Carson because it reminds him of a traumatic event, so he prefers to pick his prescription at closest Walmart. He denies substance abuse, denies head injury. He also experienced fear, reports flashback, detachment from others, trouble concentrating, loss of pleasure, and suspect that the hearing loss is related to compensatory auditory hallucination rather than genuine psychosis. He meets the criteria for MDD. 6 out of 9 required symptoms for MDD, which include depressed mood, diminished interest or pleasure, decreased appetite, insomnia, fatigue, diminished ability to concentrate, and this is not related to physiological effect of substance or medical condition. He also meets the criteria for PTSD, which include exposure to traumatic event, criterion A1, recurrent dream, persistent avoidance of distressing dreams, inability to remember important aspects of the trauma. He also have poor or problem with concentration, and the disturbance is not attributed to substance abuse or medication. For his mental status examination, he appears older than stated age, but well-dressed and cooperative during the interview. Moral activity, he displays no tremors, restlessness, or abnormal gait. Speech is fluent, clear with normal tone, rate, and volume. Mood is with minimum anxiety, no sadness, guilt, or anger. His affect was euthemic, so I think he's suppressing, some of his emotions. For thought content, there is negative of obsessional and compulsive thought. His thought process is linear, organized, and goal-directed. He reports hearing voices, and you are suspecting is related to meningitis. He's alert and oriented to place, time, and person and situation. Abstract reasoning is good. He has a full insight. He has a capacity to make good decisions and act on them. What was unusual about this client is elderly, very vulnerable, and he lives alone. He has a number of risk factors. His age is 70 years old. Severity of his trauma, the duration that he has had traumatic events, and availability of support. He doesn't have immediate family in town. He also stopped therapy due to lack of motivation. Psychiatric alliance. One of the psychiatric alliance that I identify is my relationship with him. We were able to build a rapport, and he had space to express his thoughts and feelings about his abuse and maltreatment. There was also a direct interview approach, especially when assessing suicidal risks, and the interview was non-judgmental. That actually helped to build a therapeutic alliance. Strengths and weaknesses, his assets, he is able to access medical treatment and ready to try therapy. His liabilities, he drinks and he has history of treatment non-compliance. Recommendation, baseline lab, CBC, CMP, lipid panel, TSH, and hemoglobin A1C. I encourage him to sleep, get some spiritual and family support, that he continue calling his family in California. Also recommended EMDR, group therapy, and to call office for any concerns, and he was scheduled to visit the office in about 3 to 4 weeks. For medication and possible contraindication, Zoloft. He was allergic to Zoloft, and it made him stay awake at night. For Prozac, he reports some agitation, so he didn't do well with Prozac. For Wellbutrin, he responded well. For Neurontin, he also responded well as well. And then the next one is epidemiology. PTSD is prevalent in the United States. Lower estimate is seen in Europe and most Asian, African, and Latin American countries, clustering around 0.5% to 1%. The rate of PTSD are higher among veterans and others who vocational increases the traumatic exposure, e.g. firefighters and policemen. Higher rates are found among survivors of rape, military combat, captivity, and genocide, and lower rates among older adults compared to general population. There's also higher rates have been reported among U.S. Latinos, African Americans, American Indians, and lower rate has been seen among Asian Americans. It's also more prevalent among females than males. Men and women define the traumatic exposure. Men, trauma is usually combat experience. Women is assault and rape. And most likely occur in single, divorced, widowed, socially withdrawn, and low economic level people. And first degree biological relative with depression increases the risk. Anyone can be affected and no one is immune. Cultural related diagnostics. The risk of PTSD may differ across cultures. Different culture experience different traumatic exposure and they react or express their symptoms differently. Pathophysiology emphasis is focused on catecholamines, glutamatic, GABA, cannabinoids, among others. There's also exposure to traumatic events also activate amygdala, which is the fear center. And in addition to amygdala, the hippocampus in PTSD plays an important role in learning and memory. MRI shows that the hippocampal and amygdala volume are reduced compared to a normal person or person without PTSD. And this shows areas of the brain that are affected by PTSD, prefrontal cortex, amygdala, and hippocampus. And this one shows the size or the volume of the hippocampal is actually reduced in PTSD compared to the normal person. Evidence-based practice, evidence-based treatment of PTSD. The first is SSRI, SNRI, and then alpha androgenic receptors, e.g. prazosin, to reduce nightmares. Evidence also shows cannabinoids may help to reduce PTSD symptoms. Agents like benzo can exacerbate response to trauma, so they are not usually used. And the present guidelines recommend CBT, CPT, prolonged exposure therapy, brief eclectic psychotherapy, and EMDR. Others also consider treatment working with the therapists from trauma-informed approach. And then group and family therapy. Group therapy has been shown to be successful in Vietnam and survivors of catastrophic disasters. For Hispanic cultural consideration, they often believe that it's unnecessary to continue psychotherapy once symptoms abate. There is a balance of hot and cold. Illness may be caused by evil eye, and there is also strong religious association. They also they use like preventive prevention, eating properly, wearing religious medals, the use of curanderas. They are also concerned with addiction, and they prefer injection rather than oral medication. Prognosis and discharge. With proper treatment and intervention can potentially improve PTSD. We continue with Wellbutrin and Neurontin and Prazosin 2 milligrams at bedtime. We started Nemenda 5 milligrams at bedtime times 4 weeks as a trial to remove the false signal. Remember, we said that he was hearing voices, so we are not sure whether those voices are genuine or not. And then explain the risks and interaction of medication at length, and he's ready to try therapy. Also recommended EMDR and PTSD Coach, an app that I was able to help him download so he can use that to manage the symptoms, develop and implement coping skills to carry out normal responsibility, and encourage patients to continue with therapy. Call the office if there is any concerns, and is scheduled to visit office in 3 to 4 weeks. And those are my reference. Thank you very much. Bye.